My name is Abigail Knowles, a fourth-year medical student at Rutgers Robert Wood Johnson Medical School. In a video titled Recurrent and Chronic Headaches, on this channel we focused on primary and secondary headache syndromes. In this video, we are going to dive into a topic of thunderclap headaches.
This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised.
We do not have any relevant financial conflicts to disclose. As always, the case presented in this talk was modified for teaching purposes. This talk assumes that you have a basic understanding of how to interpret common neuroimaging. If you need a refresher, take a look at the Brain Imaging Crash Course on this channel.
We will start by introducing a case of a patient with the worst headache of life. When we, the neurology team, are consulted to see a patient with the worst headache of life, it's imperative that we distinguish the wolf from the sheep, so to speak. So next, we will define a thunderclap headache. Timing is everything. And go through the pathological differential diagnosis. Having a solid differential is great, but next we will need to understand the imaging studies that will help us arrive at the final diagnosis. We will then return to our case to apply our knowledge. And for the remainder of the talk, we will focus on one particular cause of thunderclap headache, reversible cerebral vasoconstriction, and discuss its treatment principles. And finally, we will summarize with the diagnostic algorithm. So let's begin with the case. Today we are seeing a previously healthy 49-year-old woman who was recently diagnosed with depression and now presents to the emergency department with the worst headache of her life. The headaches are new onset and have been happening for the past 10 days. Ibuprofen was working, but today's headache came on so suddenly and became very severe within a minute or so. The pain is 15 out of 10. The patient became nauseated, she vomited, and when asked about any new medications, she recalls starting escitalopram, a selective serotonin receptor inhibitor, for her depression. You're tempted to ask about any falls or trauma to the head. Omit it. Instead, what you should be trying to ask is about subclinical trauma. Maybe the patient kickboxes and spars frequently, or pays frequent visits to her massage therapist who manipulates her neck. Our patient did none of that. Let's do an exam. Our patient is severely hypertensive, but the rest of her vitals seem normal. She is awake, alert, following commands, and visibly in distress. Her language is normal. There are no pupillary abnormalities, lacrimation, salivation, eyelid edema, conjunctival injection. Otherwise, focal neurological deficits are absent. Our screening neurological exam did not yield any useful findings, and you're concerned that maybe this is not a benign headache. In medical school, we learn that the worst headache of one's life is a buzzword for something dangerous. Subarachnoid hemorrhage, for example. The problem is that when a patient comes to the emergency department because of a headache, odds are this is going to be the worst headache of their life. That's why they came to the hospital after all. Statistically speaking, most people with a terrible headache have primary headache, which are usually more benign. But how do we distinguish a dangerous cause from a benign one? This is where the time to maximal intensity of pain is really important. I mean the time frame from when the pain starts to when it peaks. A primary headache like cluster or migraine may take 30 minutes or several hours to become terrible. The term thunderclap headache is reserved for headaches that reach maximal intensity in minutes. So a thunderclap headache is not just the worst headache of life, but it's really the fastest, worst headache of life. And it's really important that we get this classification correct. Thunderclap headaches have a higher likelihood of dangerous causes. To be more precise, for a headache to be labeled as thunderclap, it has to be first severe, at least 7 out of 10 on the pain scale, instantaneous in onset, so the headache usually peaks in less than 5 minutes, and it has to last for a minimum of 5 minutes. That last one is not really necessary to remember, since people usually only come to the emergency department if a headache persists. Does our patient have a thunderclap headache? Yes. So, our previously healthy 49-year-old woman who recently used SSRIs for a newly diagnosed depression and then developed a thunderclap headache. Our exam showed no evidence of focal neurological deficits, pupillary changes, autonomic signs, or papilloedema. What are the possible causes of our patient's headache? Subarachnoid hemorrhage usually comes to mind first, and other intracranial hemorrhages for that matter. She could be bleeding into the brain parenchyma. Reversible cerebral vasoconstriction syndrome, spontaneous dissection of neck arteries, posterior reversible encephalopathy, acute hydrocephalus or mass effect from a mass lesion, cerebral venous thrombosis. Could this be a primary headache, such as a migraine or a cluster headache? Absolutely. And I bet you haven't heard about some of these. So let's talk about the differential diagnosis of thunderclap headache. In a patient with a new headache, the list of causes is long. In our video on chronic and recurrent headaches, we discussed the causes of non-thunderclap headaches, causes like primary headache disorders, neuropathies, and facial pains, and some secondary headache disorders as well. In patients with non-thunderclap headaches, the chance of serious intracranial pathology is low, about 1 in 15. However, when it comes to thunderclap headache, that chance increases to 1 in 10. Don't get me wrong, the majority of thunderclap headaches are still thankfully benign. Migraines, cluster. But we have to be more vigilant in these patients not to miss something serious. If we discount the benign causes of thunderclap headache for a moment, the dangerous causes can be subdivided into 3 categories: cerebrovascular disorders, intracranial pressure issues, and mass lesions, cerebral infection. And if we think about these 3 general categories, one might argue that cerebral infections, like aseptic meningitis, will present with additional signs and symptoms beyond just that of a headache. So, in patients like ours with an isolated, sudden and severe headache, a dangerous thunderclap headache is really cerebrovascular, or due to intracranial pressure dysregulation. In the cerebrovascular category, the 2 most common disorders are aneurysmal subarachnoid hemorrhage, which is by far the most dangerous, and reversible cerebral vasoconstriction syndrome, or RCVS for short. These 2 disorders are major causes of secondary thunderclap headache cases. Cervical arterial dissections and posterior reversible encephalopathy syndrome, or PRES, may also cause a thunderclap headache. Intracranial pressure dysregulation category includes hydrocephalus and space-occupying lesions like neoplasms. But both high and low intracranial pressure can cause a thunderclap headache. So, intracranial pressure dysregulation category includes spontaneous intracranial hypotension. First, we will dive into a review of cerebrovascular pathologies. Here's an illustration of head and neck blood vessels in a person looking away from you. This is actually a 3D rendering based on the invasive vessel imaging modality called digital subtraction angiogram. Towards the bottom of the slide, we have the internal carotid arteries and vertebral arteries of the neck. The circle of Willis is made up of anterior circulation, which are the intracranial ICAs and their branches. The first segment of the MCA is called the M1, and the first segment of the ACA is called A1. And the posterior circulation, the terminal basilar artery, and PCAs that are not pictured here. In the next section, we will review vascular imaging. So knowing which parts of this vascular tree are affected can provide us clues to the mechanism of injury. For example, aneurysmal subarachnoid hemorrhage is caused by the rupture of aneurysms that weaken vessel walls at the branch points of the circle of Willis. Reversible cerebrovasoconstriction usually affects the more distal, medium-sized cerebral vessels. Smaller arterioles, closer to the PL surface, are affected by inflammatory and infectious vasculopathies. And finally, spontaneous arterial dissections usually affect the mobile segments of the internal carotid arteries in the neck. But this is just an oversimplification that you can use as a helpful schematic. The most common underlying pathology for an isolated thunderclap headache is aneurysmal subarachnoid hemorrhage. It's really the diagnosis that should be considered first, especially in patients over 40 years of age. And that's why it's been drilled into you through all of med school. Headache is the main symptom in over 2/3, and half of subarachnoid patients present with a thunderclap headache. As the aneurysm bursts, the blood exits the ruptured blood vessel and mixes with the CSF. Blood and the byproducts of its breakdown irritate the meninges, and the patient then develops signs and symptoms of meningitis. In a patient with a thunderclap headache, if additional neck pain or stiffness is present, the likelihood of subarachnoid hemorrhage increases nearly 7 times. These symptoms will generally persist for days to weeks until the blood and its byproducts are physiologically reabsorbed. Impaired consciousness from inhibition of the reticular activating system is another symptom of a dangerous pathology. People with a migraine just simply shouldn't pass out. Days to weeks before a major subarachnoid hemorrhage, some patients report a history of sudden and severe headache. The theory behind this so-called sentinel headache is that before an aneurysm ruptures, it undergoes structural changes like stretching or thinning, and it may leak small amounts of blood. The problem is that the concept of this so-called sentinel headache is based largely on retrospective data. That is, it's prone to bias, and longitudinal studies tell us that unruptured aneurysms are rarely the causes of acute headache. So take this one with a grain of salt. History of smoking and hypertension are associated with aneurysm formation, but the absence of risk factors certainly does not rule out aneurysmal subarachnoid hemorrhage. Finally, if there are focal neurological deficits, they might head to the location of the aneurysm. The most frequent locations of the aneurysm rupture include anterior communicating artery, internal carotid artery, and the ophthalmic and posterior communicating arteries that branch from it, middle cerebral artery, and the basilar artery tip. Let's take a moment to review signs and symptoms of aneurysm rupture at these various anatomical positions. In practice, aneurysmal subarachnoid hemorrhage is not very localizable, but this localization exercise is still helpful for the diagnosis of large, unruptured aneurysms and other lesions causing focal neurological deficits. Anterior communicating artery aneurysms may compress the optic nerves or the optic chiasm and cause vision deficits. They are also adjacent to the frontal lobes and may cause frontal lobe dysfunction, like abulia, lack of motivation to perform actions. Motor fibers for the legs are located medially in the frontal lobe, so lower extremity weakness may also happen. An infamous sign of the larger internal carotid or posterior communicating artery aneurysms is ocular motor dysfunction. That's third nerve palsy. Unless proven otherwise, acute third nerve palsy with ipsilateral pupil dilation is potentially an aneurysm. But why? Well, imagine an axial cut through the orbits. Midbrain is in the middle, from which the third and fourth cranial nerves originate. The sixth cranial nerve that comes down lower from the pons supplies the lateral rectus muscle. Third cranial nerve travels next to the posterior communicating and internal carotid arteries. A large internal carotid artery aneurysm may compress that third nerve. Also, cranial nerves 3, 4, and 6 travel through the cavernous sinus, and a lesion that impinges on the cavernous sinus may cause ophthalmoplegia, complete paralysis of the ipsilateral eye. You are probably familiar with the middle cerebral artery syndrome that happens when the vessel is occluded, causing ischemia. Well, with the middle cerebral artery rupture, the symptoms and signs will be very similar. Contralateral hemiparesis with aphasia on the dominant side, or visual spatial neglect on the non-dominant side. And finally, basilar artery aneurysm. This may cause signs of brainstem dysfunction and impaired consciousness. Okay, let's travel away from the circle of Willis to more medium-sized vessels and discuss reversible cerebral vasoconstriction. The clinical presentation of RCVS is usually dramatic, with a sudden and severe recurrent thunderclap headaches over the span of a few days. The duration of each recurrent headache is usually shorter than with aneurysmal subarachnoid hemorrhage. It's measured in hours, not days to weeks. As the name suggests, vasoconstriction or vasospasm usually happens because of dysfunctional regulation of cerebral vascular tone. Cerebral blood vessels are richly innervated by sympathetic nerve fibers, and sympathetic overactivity is to blame, or at least in part. So RCVS is often brought on by a stimulating vasoconstrictive trigger. And there are many such triggers: stimulants, cold suppressants like pseudoephedrine, selective serotonin reuptake inhibitors, chemotherapeutic agents, certain energy supplements, and many, many more. A vessel in spasm can cause hypoperfusion and may ultimately result in brain ischemia. A vessel in spasm can also rupture, resulting in subarachnoid hemorrhage. So, take note that an aneurysm is not the only mechanism of a subarachnoid hemorrhage. Because RCVS involves the more distal, medium-sized cerebral vessels, the subarachnoid bleeding will be in the higher brain convexities, and not just at the base of the brain adjacent to the circle of Willis, where we would expect aneurysmal subarachnoid to occur. Risk factors can certainly help with the diagnosis. Female sex and pregnancy, or more specifically the postpartum period, are well recognized. Why? Well, cerebral vessel walls contain gonadal hormone receptors. Estrogen then modulates the vascular tone, cerebral blood flow, and the permeability of the actual blood-brain barrier. But remember, risk factors are not everything. Absence of a risk factor cannot exclude RCVS. Next, spontaneous cervical arterial dissections. I say spontaneous to mean without severe neck trauma. I say cervical because the dissections of the neck vessels are more common than the dissection of the intracranial vessels. And carotid dissections are much more common than vertebral dissections. First, what is a dissection? Well, look at this illustration. Here you can see the common carotid artery bifurcating. It bifurcates into the internal carotid and the external carotid with branches into the neck. Normal flow of blood is anterior grade towards the head. A dissection is a tear in the intima. This tear causes the formation of an intimal flap, which allows blood to penetrate into the muscular portion of the vessel wall, the so-called false lumen. The expanding intramural hematoma narrows the true lumen. The current hypothesis is that the pre-existing weakness of the vessel walls, because of the undiagnosed connective tissue disorder perhaps, combined with subclinical trauma, sets these events in motion. Subclinical trauma could be something as trivial as close contact sports, chiropractic maneuvers of the neck, coughing, retching, and even neck strain during childbirth. Dissections are a rare cause of thunderclap headache. So why are we even talking about them? Because significant headache and cervical pain is a prominent presenting feature in over 80% of these patients. Of course, pain by itself is really nonspecific. But about 1/3 of patients with carotid dissections may also develop Horner syndrome, ptosis, meiosis because of sympathetic fiber damage. And compromised blood flow to the ophthalmic branch of the internal carotid artery can cause transient monocular blindness. So, headache or neck pain with Horner's and monocular vision loss in a patient with neck strain after repeated bouts of coughing makes a really good story for a cervical carotid dissection. The most feared complication of a dissection is ischemic stroke. Thankfully, stroke is rare. How does dissection cause ischemic stroke? Strokes happen by two mechanisms. The intramural hematoma expands significantly to obstruct forward blood flow in the true lumen, in which case the carotid circulation is hypoperfused. But much more commonly, thrombi break off from the hematoma and embolize distally. Okay, So far, we've talked about neck vessel injury, that's dissections, rupture of aneurysms in the circle of Willis, and reversible vasospasm of the medium to small vessels. Now, let's review a pathology that affects the smallest component of our cerebral vasculature, the neurovascular unit. First, we are going to review what the neurovascular unit is, and then we're going to look at some of the pathologies that arise when this unit is disrupted. Let's zoom in on the Peel artery. These arteries line the surface of the brain. They are surrounded by smooth muscle cells that contract and relax to control the diameter of these arteries. Peel arteries then descend into the brain parenchyma. They narrow and branch and become penetrating arterioles. And penetrating arterioles eventually branch more to become a dense network of capillaries. These capillaries are surrounded by contractile cells called pericytes. Conceived simply, pericytes are to capillaries as smooth muscle cells are to the Peel arteries. Of course, they have other roles like maintaining the blood barrier, regulating angiogenesis, inflammatory responses, etc. Next to the vasculature, inside the brain parenchyma, you will find neurons, microglia, and astrocytes. Now, if we take a look at one of those capillaries in cross-section, we get to the most important component of cerebral vasculature, the neurovascular unit. Neurovascular unit is made up of capillary endothelial cells, connected by tight junctions, foot processes of astrocytes, pericytes, and surrounding neurons. This neurovascular coupling is really crucial. It gives the blood-brain barrier its functions of regulating blood flow and nutrient exchange. The integrity of the neurovascular unit is maintained in part by these tight junctions. They seal the blood vessel lumen from the CNS parenchyma. Why are we even talking about this? You might remember that the neurovascular unit regulates cerebral blood flow across a range of blood pressures. If the mean arterial pressure falls, arterioles will dilate to maintain stable cerebral flow. Eventually, of course, the mean arterial pressure may become so low that autoregulation fails, and the brain is hypoperfused. This happens in acute ischemic stroke, but really that's a topic for another video. We are more interested in discussing what happens when the mean arterial pressure rises. Initially, the arterioles vasoconstrict to maintain stable cerebral blood flow. Now let's say the systemic pressure is too high, something that happens in hypertensive emergency. Autoregulation is overwhelmed, and the neurovascular units become leaky. Blood-brain barrier breaks down and fluid accumulates in the interstitium of the brain parenchyma, resulting in vasogenic edema. This condition is called posterior reversible encephalopathy syndrome, or PRES for short. Thunderclap headache is rare with this condition, but it does happen. As vasogenic edema increases in the subcortical white matter, patients develop progressively worsening headache with signs of elevated intracranial pressure, like altered levels of alertness. Did you catch that? Edema forms at the gray-white junction in the subcortical white matter. That's why the term leukoencephalopathy is in the name of this condition. PRES is not always posterior, but why is it predominantly posterior? Well, presumably, there is decreased sympathetic innervation in the posterior circulation vessels, so rapid rises in the blood pressure can overcome autoregulatory capabilities more easily. With edema of bilateral occipital lobes, we would expect significant vision decrement, and even cortical blindness. Seizures happen frequently in this condition, in about 2/3 actually, as the cortex becomes irritated by edema. High blood pressure, like in hypertensive crisis or eclampsia, is the more common cause of PRES. We know the definition of hypertensive emergency: severe hypertension with end organ damage. In this case, the brain is that end organ. Besides hypertension, there are other ways to disrupt the integrity of this neurovascular unit. Endothelial dysfunction that is seen in eclampsia and PRES can also be caused by the circulating toxins released during sepsis, immunosuppressive medications, and even chemotherapeutic agents. These can cause similar injury to the neurovascular unit and increase permeability of tight junctions. By the way, if edema continues to progress, at some point, either capillaries rupture causing hemorrhage, or arterial flow is compromised, causing ischemia. PRES and RCVS have that in common. So posterior reversible encephalopathy is unfortunately not always posterior, as the name would suggest, and it's not always reversible. Speaking of vasogenic edema, the brain has arterioles, but it also has venules, and together those form a capillary network. So thrombosis of cerebral veins and dural venous sinuses may obstruct blood drainage from brain tissue, increasing that venous pressure. The increase in venous and capillary pressure leads to blood-brain barrier disruption, causing vasogenic edema. Cerebral venous thrombosis, or the venous clots in the major veins and venous sinuses of the brain, generally present as 4 clinical syndromes. These 4 presentations are not necessarily mutually exclusive. Over 90% of these patients have a headache. Really, that's why we're discussing this entity in this talk. But the headache is usually gradual in onset. Only about 5% experience a thunderclap headache, but still, it can happen. And only 1 in 6 have isolated headache. Usually, there are symptoms and signs of elevated intracranial pressure accompanying this headache. Increasing venous congestion and pressure decreases local perfusion, causing ischemia. This can result in a venous infarction or a hemorrhage, similar to PRES. So in these cases, cerebral venous thrombosis may present with focal deficits that correlate with the area of infarction. And focal deficits are easy to localize. There are 8 clinically relevant venous sinuses: superior sagittal sinus, straight sinus, 2 transverse sinuses, 2 sigmoid sinuses, and 2 cavernous sinuses, which are not pictured. Let's go through some localizable signs and symptoms. What deficits would you expect if you thrombose the transverse sinus, draining the dominant hemisphere? Did you say aphasia? Yes. Transverse sinus drains the temporal lobe, where Wernicke's area and associated language sensors resides. Thrombosis of the straight sinus and deep draining veins will compromise structures of reticular activating system and cause encephalopathy and coma. Thrombosis of cavernous sinuses impairs cranial nerves 3, 4, and 6, responsible for eye movement. And that results in painful ophthalmoplegia, paralysis of the ipsilateral eye. With enough edema and cortical irritation, about 7% of patients develop seizures, just like with PRES. As far as causes, cerebral venous thrombosis is associated with hypercoagulable states. Okay, so cerebrovascular pathologies are the most common cause of thunderclap headache. Aneurysmal subarachnoid hemorrhage and reversible cerebral vasoconstriction are at the top of that list. Let's divert our attention to the other important group: disorders causing intracranial pressure dysregulation. We were just talking about signs and symptoms of elevated intracranial pressure with cerebral venous thrombosis. Another entity that can create the same clinical picture is hydrocephalus. Here's an illustration of a normal ventricular system, with CSF flowing from the lateral ventricles to the third ventricle, passing through the cerebral aqueduct into the fourth ventricle, and then eventually into the subarachnoid space. Now imagine a mass lesion within the third ventricle. It can act like a ball valve, suddenly blocking the foramen of Monro. Lateral ventricles dilate under pressure, and over 70% of these patients experience a sudden headache, with half developing symptoms of elevated intracranial pressure. These are nausea, vomiting, lethargy, loss of consciousness. And the most common such intraventricular mass is a colloid cyst. Colloid cysts are non-malignant, mucin-filled lesions. They are very rare, but they are still an important diagnosis to consider in patients with thunderclap headache, because obstructive hydrocephalus can be deadly. You can spot third ventricular colloid cysts along with radiographic signs of hydrocephalus on brain CT and MRI. But more on imaging when we get to the section on diagnostic testing. Another dangerous but thankfully rare cause of excruciating headache is pituitary apoplexy. This condition involves hemorrhage of the pituitary gland, usually with a pre-existing pituitary macroadenoma. Pituitary apoplexy is not, strictly speaking, a disorder of intracranial pressure, but it does cause local mass effect. So patients get the usual symptoms of headache, nausea, vomiting. But how do we differentiate pituitary apoplexy from other causes of thunderclap headache? Let's bring back the coronal illustration of the sella and cavernous sinuses. This patient is looking directly at you. What happens if we add a hemorrhagic macroadenoma? Optic chiasm and optic nerves are compressed, causing visual impairment. This happens in up to 80%. Cranial nerves responsible for ipsilateral eye movement are also compressed and injured in and around the cavernous sinus. This causes paralysis of the ipsilateral eye. This happens in every other patient. You might say that this clinical presentation looks very similar to cavernous sinus thrombosis. And you would be right. Only imaging can reliably differentiate these entities. But with a sellar mass, there may also be signs of endocrine dysfunction. We would be looking for signs of hypopituitarism. Think hypotension and low levels of hormones normally produced by the pituitary. All this time, we've been talking about elevated intracranial pressure. But decreased intracranial pressure can also be painful. Let's say a person loses CSF. There's a reduction in the buoyancy of the brain's supportive cushion. The brain sags in the intracranial cavity, stretching the pain-sensitive sensory nerves, ligaments, and bridging veins. This traction is worsened by gravity. So the headache is classically positional, or orthostatic. What this means is that the pain worsens on standing and subsides when lying down. And this finding is amazingly reproducible. While most of the time the headache with intracranial hypotension is not really a thunderclap headache, it can be sudden, and it can reach peak intensity relatively quickly, within about 15 minutes probably. Along with the headaches, nearly half of the patients experience additional symptoms, like vestibulocochlear symptoms, disequilibrium, gait instability, nausea and vomiting, muffled hearing and tinnitus, probably because of the traction on the cerebellum and related structures. These symptoms are not very specific, but taken together with the orthostatic headache should increase suspicion for intracranial hypotension. Why would a person lose CSF? Usually trivial trauma, perhaps superimposed on some underlying connective tissue disorder that causes a dural tear in the cervical or thoracic spine. This produces a CSF leak from the spinal cecal sac. Confirmation of this diagnosis generally requires MR imaging of the brain and spine. In the final category of disorders that should be considered in patients presenting with a thunderclap headache are cerebral infections, like aseptic meningitis. So let's spend a moment on those. Overwhelming majority of meningitis cases present with gradual headache, but 3% of the time, the headache is thunderclap. Aseptic meningitis due to viral illness is much more common than bacterial meningitis. So these patients may not have the usual toxic appearance, like nuchal rigidity and acute confusional state. Aseptic meningitis often presents with several days of fever and a headache, perhaps associated with signs of meningeal irritation, like a stiff neck, nausea, photophobia. And approximately half of the patients with meningitis may not present typical meningeal symptoms and signs. Even when they do, specificity of these signs is less than 70%. So fever with a headache should be enough to consider a cerebral infection in the differential. Just as with any infection, travel and exposure history gathering may be helpful. Infection is not the only cause of meningeal irritation. For example, blood byproducts can cause chemical meningitis. We saw this in our discussion of subarachnoid hemorrhage. So really, imaging and lumbar puncture becomes necessary for this diagnosis. So now that you know the differential of thunderclap headache, what additional symptoms and signs may be helpful in the diagnosis? First, repeated bouts of thunderclap headache in the absence of any other worrisome clinical signs or symptoms are suggestive of reversible cerebral vasoconstriction syndrome. Fever and meningismus may be suggestive of cerebral infection. Signs of meningeal irritation without a fever are seen in subarachnoid hemorrhage. Depressed consciousness and confusion could be symptoms of elevated intracranial pressure. We see this in PRESS, cerebral venous thrombosis, pituitary apoplexy, acute hydrocephalus, and, of course, meningitis. Focal neurological deficits mean focal brain lesions. Think venous infarctions with cerebral venous thrombosis, PRESS with worsening cerebral edema, RCVS with ischemic or hemorrhagic complications, or cervical arterial dissections complicated by ischemic stroke. Ophthalmoparesis, paralysis of eye movement, is a very specific focal deficit. It suggests involvement of the cavernous sinus. Think cavernous sinus thrombosis or cellular mass effect from pituitary macroadenoma and apoplexy, for example. Seizures are simply a symptom of cortical irritation. Aneurysmal subarachnoid hemorrhage, bacterial meningitis, PRESS, and venous sinus thrombosis are fulminant enough to trigger a seizure. Horner syndrome is a sign of sympathetic dysfunction that may be caused by cervical carotid dissections. What's orthostatic headache a feature of? Yeah, that's right, spontaneous intracranial hypotension. Severe hypertension raises concern for hypertensive emergency, or PRESS, although it's not particularly specific. Ischemia and hemorrhage can also trigger a catecholamine surge, resulting in hypertension. Peripartum period increases the risk of coagulopathy. Think cerebral venous thrombosis. It also increases the risk of eclampsia and pituitary apoplexy. For our patient, what are the top 4 diagnoses? Aneurysmal subarachnoid hemorrhage, reversible cerebral vasoconstriction, posterior reversible encephalopathy syndrome, or hypertensive emergency, and cervical artery dissection. Exactly what I was thinking. We are not seeing signs or symptoms of elevated intracranial pressure, so we're less concerned about hydrocephalus, cerebral venous thrombosis, or a mass lesion. Our patient doesn't have a fever, so cerebral infection is much less likely. Statistically speaking, most likely this is a primary headache, like a migraine, but we can't call it a primary headache until we have excluded the more dangerous causes. What are the next diagnostic steps? CT. Sure, it's a great place to start. Here are the 3 images from one patient. Can you describe them? That's right. This is a non-contrast head CT with axial cuts through the midbrain and the interpeduncular cistern on the left. The hypothalami, the third ventricle, and finally the basal ganglia, with lateral ventricles on the right. Does anything strike you as abnormal? Remember that fluid is dark or hypodense on the head CT. Yes, there is extensive hyperdensity in the sylvian fissures, interpeduncular cisterns, and interhemispheric fissure. These hyperdensities are within the subarachnoid space, so this CT is showing us diffuse subarachnoid hemorrhage. Some of this hemorrhage is spilling over into the ventricles. Now, how about these images? These 2 patients presented with isolated thunderclap headache. What is abnormal? First, these CT cuts are at the frontoparietal level. They are higher than the previous example. On the left, the serpentine hyperdensity follows a sulcus in the left frontal lobe. On the right, the hyperdensity is in the right frontoparietal area, again, inside the sulcus. These are also examples of subarachnoid hemorrhages, but these hemorrhages are in the convexities rather than closer to the circle of Willis. What is happening here? Sure, this is another example of a diffuse subarachnoid hemorrhage. What else did you notice? Look at the temporal horns of the lateral ventricles. They are very dilated. This is actually one of the earliest signs of hydrocephalus. Actually, if you show the first example again, those temporal horns look enlarged too. What about this CT? How are the temporal horns? Right, dilated. So this patient also has hydrocephalus. But you may have noticed a homogeneous hyperdense rounded mass lesion within the interior third ventricle blocking the foramen of Monro. This is a colloid cyst, which is causing obstructive hydrocephalus. Next example. You know the drill. Identify the abnormalities. There is a region of hypodensity in the right frontal lobe. The hypodensity is sparing the cortex. This is vasogenic edema due to blood-brain barrier breakdown. There is also a hyperdensity within it. Put those together and you have a very plausible picture of a venous infarction with hemorrhagic transformation, perhaps due to cerebral venous thrombosis. Next example, what's happening here? Yes, these are bilateral occipital hypodensities. Once again, the hypodensities spare the cortex. This is also vasogenic edema due to that blood-brain barrier breakdown we saw previously. Considering posterior location, this is most likely posterior reversible encephalopathy syndrome. Last example. This one is the hardest. What is abnormal? Let me show you a normal image as reference. Can you locate the expected cellar and paracellar structures, like the pituitary and the cavernous sinuses? There is a large soft tissue mass centered on the cella that expands into the cavernous sinuses. It is a hypodense cystic component. The mass is a pituitary macroadenoma, and follow-up MRI confirmed blood products within that cystic component. So you are seeing a pituitary apoplexy. Now, I hope I have convinced you that a non-contrast head CT can be very useful. But this begs the question, just how useful is it? In a recent large cohort of patients with a thunderclap headache presenting to an emergency department, head CT was positive only 8% of the time. Most common finding? Subarachnoid hemorrhage. No surprise there. So, most of the time, head CT is normal. That's okay. We know that most patients with a thunderclap headache have a primary headache disorder and not a dangerous secondary pathology. But what are the chances that head CT misses a hemorrhage? The sensitivity is 94%, so less than 6%. The sensitivity fluctuates a bit. It's highest when the CT is performed within 6 hours from symptoms onset. Beyond 6 hours, as the blood decomposes, it may become less hyperdense and less visible. So in general, this means that the negative predictive value for hemorrhage is quite good, especially in patients with normal neurological examination. But sensitivity for other pathologies like PRES or pituitary apoplexy is significantly lower. So head CT does not definitely rule out a dangerous cause of a thunderclap headache. Also, when hemorrhage is diagnosed, CT cannot identify the cause of that hemorrhage. For that, let's perform a CT angiogram. Most common causes of thunderclap headache are cerebrovascular, after all. Here's our first example. You probably noticed that the subarachnoid hemorrhage originates between the hemispheres, where you might find the interior cerebral arteries. Here's the CT angiogram of the head with contrast, axial reconstruction through the circle of Willis. I realize that this is a busy image with arteries and veins overlapping. Name the major vessels that you can see. Internal carotid arteries, middle cerebral arteries, anterior cerebral arteries. What does not belong? Yes, there is an anterior communicating artery aneurysm. You can see it even better on the more invasive digital subtraction angiogram. Here's the patient facing you. The left internal carotid artery splits into the left middle cerebral and the left anterior cerebral artery. And the aneurysm is here. The patient in the second example gets a CT angiogram. But this one is challenging. What strikes you as abnormal? How about now? Yes, the caliber of the right middle cerebral artery appears irregular. Areas of narrowing followed by areas of dilation. This turned out to be vasospasm due to reversible cerebral vasoconstriction syndrome. And it was better seen on digital subtraction angiogram. By the way, digital subtraction angiogram is the gold standard study for vasculature. Here, the stem of the MCA appears narrower than normal. Just take my word for it. We measured. Here is the patient with venous infarction with hemorrhagic transformation. CT angiogram has been reconstructed sagittally, and the patient is looking towards the left side. Here is the straight sinus and the superior sagittal sinus. What is missing? Yes, the anterior 2/3 of the superior sagittal sinus. This is a cerebral venous sinus thrombosis causing a venous infarction. And the final example, CT angiogram of the neck, coronal maximal intensity projection. Common carotid arteries are here. Internal carotid arteries are here. Can you spot the abnormality? The right internal carotid artery becomes narrower than the left, and the narrowing occurs several centimeters above the bifurcation. This patient has a cervical carotid dissection. It has been hypothesized that the mobile segment of the internal carotid artery suffers a mechanical injury from a bony protrusion called the styloid process. The longer the styloid process, the higher the risk of dissection. So non-contrast head CT plus the CTA of the head and neck with contrast is an excellent initial set of imaging in patients with signs and symptoms concerning for a secondary thunderclap headache. It will help us identify aneurysmal subarachnoid hemorrhage, hydrocephalus, vasospasm, venous infarction due to cerebral venous thrombosis, and dissections. It is much less helpful with the rare non-vascular causes of thunderclap headache, like pituitary apoplexy, breath, intracranial hypotension, or meningitis. Should we get an MRI? MRI is certainly a much better diagnostic study. In fact, it's the gold standard for many of the dangerous causes of thunderclap headache. There are 3 major problems with that. First, it's not feasible to obtain MRI in every patient with a thunderclap headache. The sheer number of patients presenting to the emergency department with thunderclap headache would quickly overwhelm any radiology department. And remember, most of those patients do not have a dangerous pathology. Secondly, MRI is generally more difficult to obtain. The scan takes longer to schedule and perform. And patients must stay perfectly still to get quality images. I don't know about you, but if I'm having a severe headache, I wouldn't be staying perfectly still. And third, advanced neuroimaging leads to incidental findings, about 2% of the time, that requires more unnecessary testing. So we need to be smart about our use of MRI. Let's say CT head and CTA imaging is negative, but we are still very clinically suspicious for a subarachnoid hemorrhage. Think of an example of a patient over the age of 40 with thunderclap headaches, who presents after an episode of loss of consciousness and now has nuchal rigidity. Oh, and that patient also has a family history of aneurysms. We can consider a lumbar puncture in this scenario. As we talked about a few minutes ago, a CT head is an excellent rule-out test for subarachnoid, making the yield for a positive lumbar puncture following a negative head CT quite low. How low, you might ask? Well, you would need to perform a lumbar puncture on 250 people to identify just one additional aneurysmal subarachnoid that you missed on CT. No wonder lumbar puncture has fallen out of favor. Performing an LP will convince us that we are not dealing with a subarachnoid hemorrhage. Subarachnoid hemorrhage is not the only dangerous pathology that causes thunderclap headache. Lumbar puncture is also useful in the diagnosis of cerebral infections. So let's review. In whom should we consider performing a lumbar puncture? Well, in all those sick patients with thunderclap headaches, plus fever, meningismus, and nuchal rigidity, depressed consciousness, acute confusion, focal neurological deficits, unless explained by neuroimaging findings, cranial nerve abnormalities, seizures, and yes, once in a while in cases where you are very concerned about subarachnoid hemorrhage but imaging is negative. So let's get back to our case. In our previously healthy 49-year-old woman who started using SSRIs for newly diagnosed depression and who's now developed bouts of isolated thunderclap headache, without fever, meningismus, confusion, eye movement abnormalities, Horner's, or orthostatic headache. Oh, and she's not pregnant. There is no evidence of focal neurological deficits, pupillary changes, papilledema, or nuchal rigidity on exam. What workup did you want to perform? Do you remember? Did you say non-contrast head CT? Here you go. You are going to have to read it. I am not reading this for you. This is a non-contrast head CT with axial cuts through the midbrain and high frontoparietal regions. And going from left to right, the first image, it's a medical student's nightmare. It's a normal image. For the astute among you who notice that the eyeballs are facing different directions, first let me congratulate you on the powers of observation. Second, she did not have dysconjugate gaze on examination. So the dysconjugate gaze here is a normal finding, because she probably took a nap in the CT scanner, and our eyes can become dysconjugate during sleep. The next two images show acute convexity subarachnoid hemorrhage in the left more so than the right frontal lobes. Is this hemorrhage likely to be because of an aneurysm or another vessel pathology? It's too high on the brain to be aneurysmal. Remember this illustration? Aneurysmal bleeding usually involves vessels comprising the circle of Willis. And there was no bleeding around the circle of Willis in our patient. So what's next? Yeah, let's look at the vessels. This is a sagittal reconstruction of the CT angiogram. Normal vessels have smooth borders. What is abnormal? If you are watching this video on your phone, now is really the time to switch to a bigger screen. The medial frontal lobe is supplied by the anterior cerebral arteries, so how about we scrutinize that vessel and its branches? There are multiple areas of stenosis in the ACA branches. Did you want to see it in 3D? Of course you do. The vessels have a beating appearance. Areas of stenosis, followed by areas of dilation. But CTA is not specific enough to tell us what is causing the stenosis. We need to consider imaging in the context of clinical history to arrive at the final diagnosis. If there were only a clinical score that could help us do that efficiently. Wait a minute. There's the RCVS-2 score. RCVS-2 score helps us distinguish RCVS as the cause of vascular abnormalities seen on imaging from other vasculopathies like dissections, vasculitis. Thunderclap headache? Check. Intracranial internal carotid artery that is not involved? Check. Remember that the RCVS occurs in more medium-sized vessels. Vasoconstrictive trigger identified? Yep. She started taking an SSRI recently. Female sex? Check. Subarachnoid hemorrhage present? Yep. We can be almost sure that this is reversible cerebral vasoconstriction syndrome. So let's talk about the management and outcomes of RCVS. Treatment principles for reversible cerebral vasospasm are relatively straightforward. First and foremost, we need to identify and discontinue the triggering substance. The list of agents reported in the literature is quite long, But think of any drugs or supplements that may have sympathomimetic or vasoactive properties. In our patient, it is likely the SSRI use. It is imperative that we find an alternative antidepressant for our patient to safely treat her depressive symptoms. Next, treat vasospasm. The pathophysiology of RCVS likely stems from vasospasm, and calcium channel blockers help with vasospasm. But this thinking is based more on observational data and based upon the treatment of vasospasm in other conditions. There is no randomized controlled evidence supporting the use of calcium channel blockers, like verapamil in RCVS. And even though we are not specifically using calcium channel blockers to treat head pain, these agents may decrease headache frequency and severity. After all, they are being used for headache prevention in patients with migraine. Your patient will inevitably ask you when her symptoms are going to go away. Thankfully, you can tell her that in most patients with this diagnosis, they have a self-limiting course and a fairly benign prognosis. Her headache should improve within 3 weeks. Vasospasm may take up to 12 weeks to resolve. And 95% of people return to functional independence. But less than 5% of the time, vasospasm progresses, causing ischemia or hemorrhage. And for those patients, more invasive interventions are necessary. This is an example of a patient that developed spasm in multiple vessels of the posterior circulation. This spasm was complicated by acute ischemic strokes in the occipital lobes. This is a digital subtraction angiogram, and the patient is facing you. You can see the left vertebral artery, the basilar artery, along with its branches. Here are the areas of spasm. And this is the image after a patient received intraarterial infusion of verapamil. Much better. Vessel caliber improved by at least 30%. So, our 49-year-old woman, diagnosed with reversible cerebral vasoconstriction syndrome, triggered by selective serotonin reuptake inhibitor that was prescribed for the treatment of depression, was treated with oral verapamil. Headaches improved within weeks, and vasospasm resolved on follow-up CT angiogram. Thankfully, we were able to avoid the invasive digital subtraction angiography. We are at the end of our journey together. Let's briefly review an approach to a patient presenting with a thunderclap headache. You are seeing a patient with a new terrible headache. Is it a thunderclap headache? Does it have an instantaneous onset? Is it severe? Is it lasting? If the answer is yes, then your patient meets the criteria for a thunderclap headache. Next, do you remember the broad diagnostic categories? Majority of these patients have a benign primary headache, but this could be a sign of an underlying dangerous pathology. Cerebrovascular causes are most likely, followed by intracranial pressure lesions and cerebral infections. Are additional worrisome symptoms and signs present? So we talked about fever and meningismus and nuchal rigidity, depressed consciousness or acute confusional state, focal neurological deficits or seizures, ophthalmoparesis or other cranial nerve abnormalities, maybe Horner syndrome, orthostatic headache, severe hypertension, the peripartum period, and hypotension. We can use these symptoms to narrow down our differential. A patient has thunderclap headache plus meningismus without fever. Think subarachnoid hemorrhage. A patient has recurrent thunderclap headaches, an identifiable trigger, like a new medicine or a supplement. Think RCVS. Thunderclap headache with Horner syndrome and cervical pain may be a sign of cervical arterial dissection, especially if there are signs and symptoms of stroke. How would PRESS present? Right, thunderclap headache plus visual field abnormalities, and then perhaps a seizure and depressed level of alertness and confusion. In a peripartum patient, presenting in such a way, you could consider eclampsia. Progressive headaches, signs of elevated intracranial pressure, focal neurological deficits, especially in a patient at risk for clotting, are really hinting at cerebral venous thrombosis. If your patient with thunderclap headaches has signs and symptoms of elevated intracranial pressure, Consider a space-occupying lesion or hydrocephalus. What if you see ophthalmoparesis and hypotension, among other signs of hypopituitarism? Consider a pituitary adenoma. Orthostatic headache that gets significantly worse when standing may be due to spontaneous intracranial hypotension. And finally, who should we suspect for aseptic meningitis? That's right, headache accompanied by meningismus with fever and maybe a recent travel or exposure history. Hopefully by now your differential diagnosis would be a bit more manageable. Proceed to the diagnostic workup, starting with the non-contrast head CT. CT is positive, you're in luck. It may help you diagnose hemorrhage, cerebral edema of stroke, the dense vessel sign with thrombosis, hydrocephalus, a colloid cyst, a pituitary apoplexy. Depending on the diagnosis, proceed to further workup. The MRI might be helpful here. So say your CT is negative. Was it done within 6 hours from symptom onset? And are concerning symptoms and signs absent? If the answer is yes to both of those questions, you are likely dealing with a primary headache disorder. And it's really reasonable to treat conservatively. Now, if the initial CT was done beyond the 6 hours from symptom onset, or concerning symptoms and signs are present, we should get further testing. Get a CTA. CTA could either show you nothing, it could show you an aneurysm, or show signs of vasculopathy. If CTA is positive for arterial dissection, vasospasm, or cerebral venous thrombosis, you have your diagnosis. And those patients will usually get an MRI to look for parenchymal injury. Let's say CTA shows an aneurysm. Is this aneurysm relevant or incidental? LP looking for xanthochromia, or a product of blood breakdown, may help you answer that question. If you diagnose a small aneurysm and your LP is positive, treat this patient as you would a ruptured aneurysm with subarachnoid hemorrhage. Finally, if CTA is negative and you're still concerned for cerebral infection, LP can also be useful in this scenario. Congratulations! I dubbed thee an expert on the old Thunderclap headache. But when you wake up tomorrow with a headache, chances are no, you don't have an aneurysm or a dissection. It's just medical student syndrome. Thank you. I'm Abigail Knowles, and this has been The Neurofile. I'll see you on the wards.